Ladies and gentlemen, welcome to season 2 of Endocast. As you can see, we have a new logo, new t-shirts, but there are the same old people presenting. So, Endocast is hosted by Ahmed Shauki. Hi Ahmed.
Hi, Francesca, and of course, my co host, Francesca Cerutti.
So, as in season 1, we asked you which topics you wanted us to treat during this podcast. And the most requested topic was VPT. So, of course, we will talk about VPT. So, what do you say, Ahmed?
So, vital pulp treatments or vital pulp therapy or treatment of the vital pulp. So, it's more than just doing a pulp capping because it was very common to do a vital pulp therapy using pulp capping. But with the better understanding of the procedures and the tissues and how it reacts to new materials, we have a very wide range of procedures that we can call it vital pulp treatments. And we aim to preserve the vitality of the pulp tissue. And this is very important because as endodontists, we are not pulp killers. We aim to preserve any healthy tissues, whether it's tooth structure or, of course, in our case, the vital pulp inside the tooth. And this is very important because it's one of the most conservative treatments that can be done when we have deep caries or caries approaching the pulp or slightly into the pulp because this will use the natural reparative mechanisms of the dental pulp to repair the situation without going into removing the pulp tissue using files, removing dentin using files, and filling it with artificial materials like guttapercha or guttapercha and sealer. So it's very conservative and it spares the patient and the tooth itself a lot of damage. So whenever we can preserve the vitality of the pulp, we are towards better and more conservative treatment. And we always say that the best endodontic treatment is that the one that has never been done.
Yeah.
So when we define a vital pulp treatment, so these are a biologically based therapy aiming at preservation of the vital pulp in order to stop the inflammation or in some instances which are the classic situation when we have immature root and we need to just continue the development of the root. I mentioned the definition, but Francesca, can you just tell us why we do vital pulp treatments and why it really matters in our patients?
Yeah, of course. And the fact that so many endodontists are doing more vital pulp treatment in these days is not because got lazy, okay, but we know that it's very important to save as much as we can of the tooth because if the pulp is vital, we have continue the position of dentine and so the tooth structure is maintained. Moreover, we don't have to forget that when we extirpate completely the pulp, we lose the proprioception of the tooth. And so that tooth might undergo a higher number of fractures, for example. In this case, if the pulp is preserved, we preserve also the sensation of the tooth. And also, we have a superior response to bacteria. And last but not least, the prognosis of that tooth is better because if we preserve the vitality of the tooth, we preserve more tooth structure, we postpone an eventual endodontic treatment, the long term survival of that tooth would be extremely better than one that was treated endodontically in the first place. And so these are the reasons why it should be good to maintain the pulp vitality. But this doesn't mean that we have to try to do a vital pulp treatment in every situation because there are specific clinical indications for this kind of treatment. And so, when do we do it? First of all, when we have deep or extremely deep decays, caries, and when the patient refers pain in general with hot or cold or with chemical stimulus. And also when there are no signs of necrosis of periodontal involvement, because in that case we are not talking about vital pulp treatment anymore. And many years ago, when I was studying, they used to say that vital pulp treatment is like you toss a coin. It's like 50-50. But if you respect the clinical indications, the success rate of this kind of treatment are extremely high, because we are speaking about 80 to 90% of success rate. And so we have to understand how to do it correctly in order to achieve this kind of success rate. What do you think, Ahmed?
Exactly. I will take the last part of your speech about the we have to do it correctly. And doing it correctly start with the proper case selection and diagnosis. And I think this is one of the pillars that are essential for a successful vital pulp treatments, because this is the only way to know if the case is indicated or not and selected for vital pulp treatment is to correctly spot the stage of the disease. And this will take us to a new classification and proposal for some new terms. Actually, it's not so recent, but it's a classification that tries to make the correlation between the clinical signs and symptoms and trying to predict the actual state of the pulp, because this is the gap in the diagnosis, because everything is sometimes subjective, sometimes objective, depending on the patient, but not reflecting the actual status of the tissue, which is the most important thing. So in this part we moved from the classic classification of two types of the disease, which is reversible pulpitis or irreversible pulpitis, to a more detailed options or disease status, uh, starting from initial pulpitis, going more to mild, moderate, or severe. So instead of having two categories of the disease, we have now four categories. And let me tell you that at each stage of pulpitis, it can be a reversible state, because in all these conditions, we can do more than one option depending on the situation, as we will mention now. So for the initial pulpitis, it's just the classic sensitivity to a cold, like cold test, for example. But it subsides immediately after removal of that stimulus. So imagine you're taking, you have a small decay, or you have a restoration, and you have eaten ice cream, and you feel some pain with the cold, but it disappears immediately after we remove that cold stimulus. And there is no spontaneous symptoms, or there is no tenderness to percussion, no apical periodontitis, of course. So these are initial pulpitis, which are precipitated by stimulation only. And we have an option of removing the cause of the problem, like leaky restoration or the caries, for example, and we can do indirect pulp treatment, like just capping it without going into the pulp. And maybe Francesca has a case that can really demonstrate that, although if we find that we have some form of more irritation, or we are not confident about the extent of the tissue that is left, sometimes we move from indirect pulp capping to direct pulp capping, and this decision is taken intraoperatively. So let's see a case from Francesca.
Yeah, this is a case in which there was a typical patient that has some symptoms while eating ice cream, okay, and you see there is an extensive amalgam restoration, so it makes sense to just remove the amalgam, okay. So in this case I did a single tooth anesthesia because I could manage all the treatment without doing some nerve blocks or similar. So rubber dam isolation, I removed the decay, but after I removed completely the decay, I have 3 small spots in which I have communication with the pulp chamber, okay? Of course, there is no indication in doing an endodontic treatment here, so I just directly cap the pulp in those spots with MTA. This is an old case, I used MTA. I gently tapped it with a microbrush in order to adapt the MTA to the small groove that I had created. Okay, it's an operation that you do in a few minutes, and then with an excavator you remove all the excesses. I protected that MTA while doing my restorative procedure, because in this case it starts setting about 15 minutes later, and so you just can wait a little bit and then do immediately the restoration, because I want to ensure a good coronal seal to the pulp and to the material. I don't want to put a provisional material that maybe washes out within some days, and so I have reinfection in that case, okay? And so this is my final restoration. After 1 year, I have the follow-up of the restoration and of the tooth. There was a pulp stone before, there is a pulp stone now. The patient was in her 70s, and this is 9 years later. So basically, nothing changed, neither in the pulp, neither in the restoration status. And this is what I can call a success. What do you think, Ahmed?
Yes, of course. Having these X-rays after so long time and no change, this proves the what we are trying to deliver, that it is one of the most conservative, and it is not just a temporary treatment. It can persist for a long time as long as the procedure is selected properly and performed in a good way. But sometimes we have another more advanced type of the pulp inflammation, which is a mild pulpitis. And in this part, we have a high-end sensitivity to a cold, for example, as in the previous example, but it persists for 20 to 30 seconds, maybe half a minute, we can say, and then it subsides on its own without any lingering. So this means that sometimes the irritation is more into the pulp, into the superficial part of the pulp, or it just needs just walling off that irritation. So we have also an option of having an indirect pulp treatment in those cases, or if we feel that there are more to be removed from the floor of the cavity, and this will lead to an exposure. So it can be, in some cases, a direct pulp treatment. So this is a mild pulpitis, and I guess also we have some images for a case like this from
Yeah,
Francesca.
yeah, exactly. This is a typical example of what you just said. A large decay, very young patient, and as you can see, I exposed the pulp because there was soft tissue. So I didn't trust that soft tissue to stay there because I don't want contamination by bacteria of that pulp in such a young patient. And so what I did was a direct pulp capping, even in this case, MTA and immediate restoration. And as you can see, also look at the second molar, 2 years later, the pulp vitality is preserved, the apexes are closing, the other tooth is erupting, and so we maintain the situation stable. Will this last forever? I don't know. But it's important for me in such a young patient to treat it in the most conservative way that I can.
So with a more advanced stage of the disease is a moderate pulpitis, we have clear signs and symptoms, which are like the classic clinical picture of acute pulpitis. So we have high sensitivity to cold that lingers. Sometimes we have a hot tooth, like we have a spontaneous pain that's continuous and only can subside temporarily with cold. And we have a diffuse pain. You cannot just determine where is the problem, upper or lower. Uh, and in some cases, we can have slight tenderness to percussion because of the inflammatory mediators involving a huge part of the pulp tissue. And this means that the inflammation is not just superficial in the coronal pulp, but it might be more deep into the pulp tissue. And in this case, we need just to have a subjective view of the tissues. You need to see that tissues, and you have to remove all the decay, which in these cases might be soft decay that should be removed. And then you can go to deal with the vital pulp through a complete or partial pulpotomy. And as usual, we have a case for that.
Yeah, we have two options here. The first one, a case of partial pulpotomy, where you see I remove all the decay, which was extensive. Okay, the patient had symptoms, and you see there is some bleeding from the pulp, but not from all of it. Okay, so I tried to address only the pulp horn that was interested by the bleeding. I just compressed a little bit with a cotton with a slight sodium hypochlorite in it, and when I was able to stop the bleeding, I just put some bioceramic putty with a VPT because in a couple of shots I finished the apposition of biomaterial. Okay, I just pack it, and then I can protect it with some Teflon and liquid dam. It's called internal isolation technique. It was described by Roberto Careddu. And then I can go on with my restorative procedure because I want to finish the treatment in one single session for the reasons that we explained before. So I don't want bacterial leakage. I want to protect the material. Of course, I'm not having adhesion on top of the bioceramic, but I'm having adhesion in all the remaining parts of the tooth, so I think it's enough, okay? And as long as the patient is free from symptom, everything works, I think. And so this is the direct restoration that I did. Nothing special, okay? So I'm just resto, and then you see the tooth, the finishing, polishing, etc. And this is the aspect of the tooth before and after removing the rubber dam. And that's the x-ray. As you can see, I touched only part of the pulp, the other part was left completely untouched. Another case, more extensive involvement of the pulp. This tooth is a premolar, only one root, okay? And as you can see here, I have to go a little bit more deeper in order to be able to see some sound pulp and to stop the bleeding. So I just did some passive rinsing with sodium hypochlorite, and then I dry, I wash the tissue, and okay, I can stop here. And so in this case also I put some bioceramic putty because I think it's the quickest option that I have. I don't have to mix it, I don't have to have my assistant mix it, and it allows me a working time that it's a bit longer than that of the conventional MTA. Then, since I want to do adhesion here, I want to remove immediately all the excess of bioceramic putty, which I do, and then, as I've shown before, internal isolation technique, so Teflon, liquid dam, okay, just to cover and protect the bioceramic putty while I am etching the tooth, because I have to etch and then I have to rinse. I don't want to wash out the bioceramic putty. And then after that, with just a probe, I break the liquid dam and I remove the Teflon. And then I'm ready to go with my primer, my bonding, all the adhesive procedure that you do conventionally in order to restore the tooth. And then you see step by step the direct restoration, even in this case, and the post-operative x-ray.
Well, that's a clear idea about a case that having moderate pulpitis and one case treated with pulpotomy and partial pulpotomy due to the involvement of more parts of the pulp in the inflammatory process. The highest and most advanced stage of the disease is a severe pulpitis, and here we have severe signs and symptoms like the moderate pulpitis, but it might be more extensive, and sometimes it worsen at night or lying down. Sometimes it can be tender to touch or biting, and of course to percussion. And in that most advanced part of the disease or stage of the disease, we have two options as always. But those options here in severe pulpitis would be either complete pulpotomy, for example, or pulpectomy, total pulpectomy, like a root canal treatment. So, depending on the objective signs of the pulp tissue when you remove the inflamed tissue and you examine with your microscope the hemostasis and the color of the tissue, and we will discuss that in the next episode, of course. We can reach whether a stage when we can perform complete pulpotomy like in the last case with Francesca, or we can do a root canal treatment. But sometimes the patient is very young and maybe the canals are very wide, and it would be a complex treatment to do a complete root canal treatment. So we can use another technique which is considered a regenerative treatment in cases where you have to remove pulp tissue that is inflamed from the root canal system until you reach a point with a healthy tissue in the apical part of the root canal. And then you will establish bleeding from that healthy tissue in the last portion or the apical portion of the root canal, and then you proceed as if it is a regenerative endodontics case. So the establishment of bleeding in this case from the healthy tissue that is remaining from the inside the root canal and not from the periapical tissue. And I will show you a case right now about this condition where we have extensive decay. And when we remove the decay on two steps from outside to the inside with different sterile instruments, of course, you will find that we have a severe inflammation of the pulp, and I cannot control the bleeding as usual in vital pulp treatment case, whether with sodium hypochlorite, saline, a flush of sodium hypochlorite, and just bleeding is not stopping. So the option here is to go and remove as much as I can until I reach the healthy tissues in the apical third, and then I do my irrigation protocol, which is a low concentration sodium hypochlorite for 5 minutes, and then we flush with 20 ml of saline for 5 minutes to make it slowly deposition, and finally with 10 ml of 17% EDTA. And in these cases, regenerative cases, we can do it in a single step or in a two-step. With a two-step, we need to leave calcium hydroxide inside the root canal, topped by Teflon, and then I temporize for 2 to 3 weeks using a resin because I don't want any leakage inside. And then in the second visit, when the patient is coming with no signs and symptoms like in the first visit, I will remove that calcium hydroxide with a flushing of saline or low concentration sodium hypochlorite, and then I will just do a final rinse of EDTA 17% over 5 minutes, dry it, and then I will establish bleeding from the apical tissues. Those tissues are pulp tissues that are not inflamed and they remain inside the root canal. If bleeding was persisting, so I will remove it and establish bleeding from the apical tissues. So it depends on the extension of inflammation. And as you see here, this is the vital tissues in the apical part of the root canal. And then I will use a sterile file and establish bleeding until the bleeding come up beneath the cemento enamel junction, and I can control the bleeding with a resorbable sponge like a collagen or a gelatin sponge. And I just place my pre-mixed calcium silicate cement like in the previous cases with just light pressure using a brush packing technique, and then we will follow with the usual restorative procedure. So now we gave an option depending on the case. So we can have an indirect pulp treatment or a direct pulp capping in minimal inflammation like initial to mild pulpitis, and then with moderate to severe pulpitis we have an option of partial pulpotomy, complete pulpotomy, root canal treatment, or regenerative endodontics. It's all based on the case.
Yeah, exactly. And I think that we will go more deep into how to do it step by step in the next episode. What do you think, Ahmed?
Yes, we need, because in this episode we just highlighted how to diagnose and what are the procedures that we're using. But in the next episode, we will go into step by step of the procedure.
Great. So, guys, thanks for watching us and stay tuned for the next episode of Endocast.
Bye.